so that they don't do that. But if something really scared it and it had to come back up quickly, then that might happen. And if we look, well, that's just showing congestion. But if we look over here, we can see some gas bubbles. There's a vessel. See how dark that is? Here's a vessel, and all of a sudden it gets light. That's where there's a gas bubble. So that's what happened here. So this well actually developed air emboli in his brain. And if I look at it histologically, that's what it looks like. Here are the blood vessels, and they got red cells on like you would expect, and they have these gaps in there. And here's really nice here. That's the air emboli. So it's possible in a well, very unusual, but it is possible. And this is again showing the bone marrow kind of emboli, and what the difference in this is showing the lipid again, the fat. But this also is staining for some of the stem cells, so that you can actually see bone marrow cells. So emboli and thrombosis. So, if I get either thrombosis or emboli in a vessel, what is that going to do as far as the supply to the tissue? It's going to diminish it considerably, and as a result of that hypoxic state, the tissue will die. So, if I have death of tissue due to interruption of arterial supply or venous drainage, that's by definition what? By definition, what? Infarction. Okay. And this, you've seen this before. This is talking about hypoxia, which is one of the main sources of injury. And in this case, that's a thrombus that's doing it. And so, infarcts. So what causes them? Usually there's some interruption of arterial flow, much more so than venous drainage. How are they classified? Well, you can call them by what they look like. They can be either red or pale. And morphology is actually an extension of that. And what is the significance of them? Well, depending on where they are. Suppose I cut off the blood supply to this finger. What's the significance of that? I'll lose the function of the finger. Am I going to die from that? Probably not. But if I cut off the blood supply to my brain, and I get an infarct there, well, I'm likely to die from that. So significance again is where it is, much more so than it just occurred. And that's just a review of the circulation, but this one doesn't have nice, pretty colors in it like the old one did, the other one did that you saw. So I put this in here so you can get some idea about what happens with murmurs. This is the right side of the heart. So if the tricuspid valve is not working properly, what am I going to get when the ventricle contracts? Regurgitation. And this is the pulmonary artery on this side. So if I got an obstruction here, what's going to happen? There's a turbulence set up by the stenotic area. So that's typically what happens with ejection kinds of murmurs. Left ventricle, same kind of thing. That's a mitral valve over there. Aorta stenosis, same kind of problem. Here's one here, ventricular septal defect. So which way is the turbulence going to go? Actually, both ways. Okay. So that's typically showing systolic murmurs. even though this one has some diastolic component too, because this is actually doing diastole as well. Okay, now, let's look at this. And now, we're not looking at ejection murmur so much so as we're looking at reflux. Remember when I told you that if the aortic valve couldn't open, it also couldn't close? So during diastole, you get backflow from both of these if that's the case. And if these are stenotic as well, during diastole, you will get a backflow. Okay, so a little bit about murmurs. Now, what do infarcts actually look like? Here is the heart. The infarct is in this area. What kind of necrosis is that? Coagulative. Okay. Over here, if we look at it histologically, we see loss of striation, some broken fibers, and a little infiltrate. And a similar kind of thing here, where the mouth filaments are broken, and there's some swelling of these cells because they're normally not that big, and broken filaments. So that's typically what necrosis looks like with EM in striated muscle. And in this one, there's a thrombus there. And what's this vessel again? The aorta. So where can it go? Down the coronaries and cause this. There's an infarct. And another one is an infarct. And there's the thrombus there, and some there. And this one is just a massive one, and that may have been due to aortic as well. So what does it look like if I'm doing CT scans and looking at EKGs? ST segment elevation is very characteristic of myocardial infarction, and there's the damage area in the ventricle. And if I look grossly, this guy dies. I look grossly, I can see this. This is an area of infarction involving the interventricular septum as well, and a little bit on the right side over here. Now this is critical in people, involvement of the septum like that. And it is because of the damage that occurs to the conduction system. The AV node and the His bundle are in the interventricular septum, but really right outside, just at the very top of it. And if the vessel that supplies that is blocked, then the individual will develop arrhythmias as a result of that. What arrhythmia do you think you would get from that? If you block or damage the bundle of His and the AV node, what's going to happen? Are you going to conduct normally down to the ventricle? So what would the ventricle do? It would fire on its own eventually. And which way would that go? Back the other direction. So if I'm looking at an EKG, when I'm normally looking at nice R wave up here, R wave is going to be in the other direction. So what do I call that? Somebody said P. Say the rest of it. PV. What's the last letter? PVCs. So you get those. Now, what's wrong with getting PVCs? Well, first of all, that's very inefficient. And secondly, those kinds of things will also predispose to fibrillation. And the animal or the human will die as a result of that. So, okay. Infarction in the kidney, and that's what it looks like. You get this nice triangular shape, and if you look at the diagram of the circulation, you can see why that happens. Now, the pulmonary, the renal artery comes in, and then you have a big artery that goes all the way around. That's called an arcuate artery. And off of that arcuate artery come the interlobar arteries, like this one, and actually that's the one that got blocked. It doesn't show you all the rest of them, but well, actually it does. There's one there, and here's one here. So if I block this, then all of the areas supplied by this will be damaged, except for the very outside. And the very outside is not damaged because you get some blood from the capsule. So this is the typical kind of infarct that you see where you have what we call end arteries, like they are in the kidney, which means one artery supplies, by itself supplies a fairly large area and discrete area, so that if it gets damaged, all of the area that is supplied by it is damaged. So there is the typical appearance. And when you look at them on the surface, it's kind of hard to tell that. By the way, what species did this come from? Bovine. Suppose I told you it was a river otter. Would I be wrong? Take a wild guess. Would I be wrong? No. River otters also have lobulated kidneys. Any other species have lobulated kidneys?
Yes. You know it is.
It's non-domestic animal, very non-domestic. Polar bears. Polar bears also have lobulated kidneys. And actually most whales do. What's the general family for whales? The word? Cetaceans. So most cetaceans do too. Okay. Now, am I going to ask you that on the test? No, I'm not going to ask you that on the test. But it's nice sometimes just to know stuff. All right. And some of you just scratched it out of your nose and I don't have to worry about that. He's not asking that. Oh my goodness. Okay, so here we go. Looking on the cut surface at an area like that, and an area like this, an area like that, and here is the intact thing. Now you see this, which is red in here, and it's got pales all around it. What do you think probably happened here? Well, and this one is all pale. Doesn't have any red associated with it. Remember I told you you could classify these things as being red or pale? Okay. Well, what happened here was that you did block a vessel, and as a result of that, the tissue died, underwent coagulative necrosis. It wouldn't look like that. But what's the difference here? Either the clot lysed, and you got reflow into the area. Now, when the reflow is occurring into this area, are the blood vessels normal in this area that have been blocked off for a while? No. So as it reflows, the blood will actually come out of the vessels and you get a hemorrhagic area like that. In this case, reflow did not occur, so it's pale all around. Most solid organs like this will tend to be pale, but you can have either lysis of the clot or you can have collateral circulation that enters these areas and make them red. So, in a kidney, most often they are pale, but they can also have red if there was reflow. And what do they look like histologically? And lack of normal kinds of structure here. All this kind of looks washed out. And the same thing is true here too. However, in this one, you can see some purplish looking area, and that's probably from some inflammatory cells coming in along the edge. And looking at them with CT scans, and this is really showing you this kind of thing, where there's thrombosis involving the kidneys, and the arrow is pointing to it nicely. You can see it. Okay. Review of circulation again. Okay, pulmonary, and that's a nice blocked vessel with CT scan. And over here, like right there, and right there on that side. And what's it look like histologically, like that? And this is actually a dog. The other one was, of course, a human. And as we look in here, here, right up there, where you see the really darker areas, that's where the problem is. And that's that same picture you saw before. Here's again another one in the lung, and the arrow is pointing to where the vessels are that are blocked, and that's what it can look like. Why do you think the lung is red almost all of the time? The infarcts you get in there are red, unless it's really, really old and chronic, then it's white because it's a scar. Why would you get a red one all the time in the lung, as versus, say, a kidney, where most of the time they're pale?
It's a double blood supply. It has more than one blood supply.
That's got something to do with infarction, but actually that's not why they're red. They're red because the tissue is very loose, and as a result of that, kidney is very compact, liver is very compact, heart is very compact, but lung is very loose. It's mostly air, and then you have some vessels. So if you damage the vessels, they'll leak all over the place. There's very little structure, so you end up with a lot of blood collecting in the air without necessarily having, quote, reflow, like you would have to have in a kidney or heart or something to see that. So in the lung, because of the organization of the tissue, you can see that. Now, she brought up a very important part about double blood supply. What is dual blood supply to the lung? What two vessels supply it? One, obviously, the pulmonary.
Yeah.
But there's another blood supply too. What? And you probably didn't see these things because they're tiny. Bronchoesophageal arteries. Okay? She's quick on Google. Because she didn't know that. But she looked it up quickly. Do you know that? For real? I'm so proud of you. All right. So some vessels, some tissues do have dual blood supply, but does that mean they cannot be infarcted? I just showed you along that one. Yeah, they can still be infarcted, but it's harder to do it. What other organ has a dual blood supply?
Liver.
Liver. And what are the two vessels there?
Hepatic.
The portal and what?
Hepatic.
The hepatic artery. And this is showing venous thrombosis, renal veins, and you actually can get infarcts as a result of, there's the infarct there. That's not in an artery, that's actually in a renal vein. So that can happen. And then you see the infarct there. This is not cut open. So that's just the big red blob there. And here. Now, if you got a venous occlusion that results in an infarct, that's going to be red anyway. Why? Because the blood's not draining out. Okay? And we might have time to do this guy. This is the last thing in this case. And this is a 6-year-old beagle. And this is a dog that's brought to you with the owner complaining about exercise intolerance. And you do know the dog because you saw him about 3 years ago and treated a cut, and it seemed to be fine at that point. And as you do your clinical examination on him, you find that he is dyspneic. He has some signs of ascites. Ascites is fluid in the abdominal cavity. How would I tell he has ascites?
Where you can sniff it like.
Percussion. That's nice. So what am I feeling for?
Is it squishy? Is it hard?
If I had a balloon, and I put some water in the balloon,
Is it jiggle?
and I tap one side of the balloon, what would happen? And I hit my other side, hit my hand on the other side. You feel a fluid wave. That's the percussion kind of thing that you do. You say, percussion. Well, yeah. Do you understand what you're doing? That's why I put that extra to it. All right. Now, if you feel a fluid wave, then you say, okay, we got fluid in there. And that goes along with heart failure, especially when you get a murmur that's on the right side. So, I shouldn't say the right side, on the correct side. Because where's this murmur probably coming from? You hear it in the third and fourth intercostal spaces. You don't hear it down on the sternal border. In the third and fourth intercostal spaces. Where? What's on that side that you can hear?
Pulmonary.
You can hear the aorta. You can hear the pulmonary artery. And well, you can hear the aortic valve. You can hear the pulmonary valve. And you can hear what? The mitral valve. Okay, that's what you can hear on the left side. Now, if it's in the fourth intercostal space, what do you think?